Hi, everyone. Welcome. We are about to start the session on the gender and UHC. We will probably wait 1 or 2 minutes before starting the session. Thank you. Thank you again for those joining us. I think we can start the panel. We have all of our panelists today. So again, hello and a very warm welcome to our distinguished speakers, guests and friends joining us from all around the world. My name is Habibu Ouedraogo. I'm a health economist and member of Women in Global Health, Burkina Faso. Women in Global Health are one of the co-conveners of the Alliance for Gender Equality and UHC. And it is my pleasure today to welcome you to this high-level event co-sponsored by UHC 2030 and Alliance for Gender Equality and UHC. For today's session, we really want to hear from you. So please introduce yourselves in the chat box, where you're coming from, your organization, and send us the questions also in the chat box, and those questions will be directed to our speakers. You can also share your thoughts on Twitter using the hashtags that we have put in the chat. I believe those will be put very soon. And to ensure full participation, we have some translation in French and in Spanish. So you can switch in the languages by adjusting the translation button. So now to start our session, as you all know, member states met this week at the 75th World Health Assembly. And with COVID-19 far from over, it is critical to raise gender responsive UHC in the context of strengthening health systems, including health emergencies. And so we will hear today from inspiring women and men. I'm very happy to see Mr. Kogon today in the panel. And these panelists will represent governments and non-governmental organizations, as well as the WHO. And they will discuss on gender and UHC policy priorities for equitable and resilient health systems. So before further ado, let me introduce you to our first speaker, Ms. Eleanor Bloomstorm from Women Deliver. So Women Deliver Alliance for Gender Equality and UHC co-convener, and she will introduce the Alliance and its work. So thank you, Eleanor, for joining us today. Ms. Eleanor is a Senior Manager, Policy and Advocacy at Women Deliver. She brings more than 10 years experience in global policy and advocacy at feminist NGOs, including Force Feminista, the International Women's Health Coalition, and the Women's Environment and Development Organization. So Ms. Eleanor, the floor is yours.
Thank you, Ms. Habibo. I'm really pleased to welcome all of you on behalf of the Alliance for Gender Equality and Universal Health Coverage. The Alliance is co-convened by Women in Global Health, Spectra, and Women Deliver. And it began in early 2019 with a handful of women's health and rights organizations who had identified there was a major gap to fill in the lead up to the 2019 high-level meeting on universal health coverage. The UHC discourse was missing a grounding in women's human rights, gender equality, and sexual and reproductive health and rights. Since then, the Alliance quickly grew, and now we have over 200 civil society organizations from more than 60 countries. and we still welcome new members if you're interested. In the Alliance, we work to co-create advocacy asks and policy recommendations based on needs and priorities of girls, women, and gender diverse people on the ground. And in 2019, we made a strong call for governments to commit to gender equality and women's rights in UHC, and it got results. The declaration includes some good language on gender, women in the health workforce, and sexual and reproductive health and reproductive rights. But now almost 3 years have passed and progress is uneven, not least due to COVID-19 and the clear impacts on gender-based violence, the cutting of health services, and the lack of protective equipment for women health workers. However, at the same time, we also know there are governments and civil society organizations and UN entities that are showing up and making progress towards gender responsive UHC by working with affected communities and supporting women's leadership. We also know that UHC is inseparable from the health system, which we'll hear much more about today from all of our speakers. Since we're at the WHA, I wanted to share the Alliance's recommendations or ways that we've identified to build stronger, more resilient and equitable health systems. And we'll continue to build on these in the lead up to the 2023 high-level meeting. So we would say that it's crucial to mainstream a gender perspective, engage feminist women and youth-led organizations in decision-making, in design, finance, implementation, and monitoring of health policies. It's crucial to ensure SRHR is an integral component of UHC essential benefits packages. We must address the social and gender determinants of health, such as harmful gender norms and institutional discrimination. We must form a new social contract for women health workers that includes safe, decent, and equal work. We have to collect, analyze, and use disaggregated data on health access information and outcomes, and out-of-pocket expenditures as well. We must take a rights-based approach and use an intersectional lens to UHC to reach the most marginalized, and of course, ensure strong primary health care that focuses on preventive care, including sexual and reproductive health needs across the life course. So I'm going to quickly put on my Women Deliver hat and just let you know that we have recently published a tool for advocates that focuses on sexual and reproductive rights as crucial to fulfilling the right to health and achieving transformative and gender responsive UHC. It's directed to advocates, but could be useful for any actors in the space as it has links to key resources, databases and monitoring tools, as well as proposed interventions for universal health coverage. And many of the headlines in that fact sheet are reflected in the Alliance priorities above. I think the one that I would add in this case is the importance to protect budget allocations for comprehensive sexual and reproductive health and rights. So it really shifts the burden from girls to women, and from girls and women to public funds. I'll share links in the document, links to the document in the chat. But that said, we really look forward to hearing from the speakers today about their challenges in implementing gender responsive UHC, but more importantly about their vision, their successes, and their practical recommendations to implement and make gender responsive UHC a reality. So over to you, Ms. Habibo. Thank you.
Thank you very much, Ms. Eleanor. We must definitely take the right lenses to approach this issue. And that's the reason why we have this diversity of panelists with us today. So thank you very much for your opening remarks. So we will now begin our panel discussion. So for the panel today, I will ask the panelists 2 rounds of questions and then invite them to discuss the topic. I will introduce each one of them as I pose the first round of questions. So my first question is for Permanent Secretary Mireille Batamuliza from the Ministry of Gender and Family Promotion in Rwanda. She has a background as a social activist working with the Imbuto Foundation, a nonprofit organization that contributes to the development of a healthy, educated, and prosperous society. So Ms. Mireille, Rwanda has a strong reputation for gender parity and women's leadership. I believe it is the first country in the world with female majority in parliament, 61% in the Chamber Deputy and 38% in the Senate. So what is your experience of Rwanda in ensuring gender mainstreaming in health system strengthening? Have you encountered any barriers? So the floor is yours, Ms. Mireille.
Thank you, moderator. And thanks a lot for Gender Equality and Universal Health Coverage and Women Deliver for the invitation. As you said, my name is Mireille Batamuriza. And I'm the permanent in the Ministry of Gender and Family Promotion. As you asked, yes, to make sure that the health, we mainstream health system, gender in health system in Rwanda. Rwanda has made the reforms of several laws and strategies at national level. I can cite the law relating to human reproductive health that guarantees equal rights to all persons, and no person should be denied the health services. The same law also recognizes that the pregnant women have given birth and newborns have the right to be cared for, so as to ensure their well-being in the Article 6 of this law. So we have also another law defining offenses and penalties that removes barriers that were hindering women and girls to access legal and safe abortion. So in mentioned predetermined conditions, women and girls fulfilling those conditions have access to the safe abortion services. Those includes being under 18, and there is no other legal procedures that are requested. So for the health system in Rwanda, I wanted to highlight that the health system in Rwanda is built starting from the community health workers that are based in the community. These are like, now we have 4 at the lowest local administrative level, where 1 among them is focusing on maternal and newborn health. Especially, we are talking about the women and girls' health related issues. So at country level, we have now around 58,000 community health-based workers. And from their work, they have contributed at the maternal mortality ratio reduction. We have now like 203 deaths per 100,000 women. So they have contributed a lot. And also we have established the community-based health insurance scheme, where the government contributes a lot for the vulnerable families under the social protection programs, and also to make sure that the health services are accessed and benefited from all categories of people, especially women. To conclude, I'm sorry. Yeah,
no,
you asked also if we have encountered some challenges. Yes, because we are in the patriarchal societies when that affects really the inequality on power sharing, affects the decision of some women when it comes to access contraceptives or other health services. So we are still working on that, and really to mobilize and educate all the general public about the women's life and the women's rights to their body, to their decisions, and to every single interaction in the household or in the community or at policy level. And also we have challenges about the infrastructure and also increasing the number of women at practitioner level where we have few female doctors, because these courses really cost a lot. Some women can't afford. Thank you.
Thank you. Thank you very much, Ms. Mirel. Thank you for sharing your insights in Rwanda, and I definitely think that it will feed into our discussions today. So now I will direct my question to Ms. Taru Kuvisto, who is the Director of the Department for Communities and Functional Capacity at the Ministry of Social Affairs and Health in Finland. Taru has extensive experience in public health. So my question to you is, Finland is one of the countries that has made positive progress towards UHC. And the country also scores highly on gender equality indices. Can you please tell us a bit about the history behind these achievements, and how has the pandemic impacted on this progress? Thank you.
Yes, thank you. Thank you so much for the opportunity to participate in this panel discussion on this important event. And really want to warmly thank you, the organizers of this session, because as you said, gender issues are for Finland an issue for long-term priority. About universal health coverage, it's something which we started already decades ago in Finland to be as a basis for all the services. Already when Finland became independent in 1917, so over 100 years ago, the first part of we tried to develop was create services for women and children already then. And so it's a long tradition. We created maternal and child health clinics. And these are going to be 100 years old rather soon. So we found already then, when Finland was rather poor country in the beginning of last century, that this is something we should invest, however, so that we give a good basis for all families and especially women and children. So it's a long way which we have gone through, and universal health coverage is nowadays implemented so that it's everyone living in Finland gets the services they need. And the latest development concerning the maternal and child health clinics, they are working well, but we have developed them about 10 years so that nowadays they are family centers. So that they are not just women and children, but also fathers. And in the centers are not just healthcare services, there are social services, psychologists, there could be some employment or some religious organizations or NGOs, so that these are collected together to work and support and provide services for families. So this is a latest development which we have taken forward. And then about the recent developments, just a couple of more words. We are just now going through a big reform of our social healthcare services. And that means that there will be even stronger basis for basic services. Primary healthcare and primary social services will be the basis for everything. And there the family centers are one of the good examples which will be near people and near the communities. So this reform is just now under preparation, and it will be implemented in the beginning of next year. But all the financial issues and organizational issues, all these are just now underway. And one of the issues which is a priority of this reform is equity. We make this reform because of that. We want to have equity and equality also between the regions, between the different municipalities, between population groups, because there have been, even though we have this universal health coverage, there are differences. Different regions have been, or different municipalities have provided really different services. And also there are some population groups inside these regions which are not getting services on the same level. So big reform, the equity and equality will be one of the main issues. And then What could also be said about the gender issue and equality is that we have for a long time had this gender impact assessment as one of the legal duties in Finland. So all the laws all the legislation which we are drafting have to go through this impact assessment before it's implemented. So that the perspective of gender have been taken into account. In addition, there's also health impacts, social impacts, children's impact, etc. But that's something which is very deeply rooted and a tradition in Finnish legislation. But not just legislation, also projects, programs. That's a principle which we are trying to implement, to have these different perspectives taken into account or given visibility before the decisions are made, so that politicians understand what are the options and what are the different consequences, so they can make wise decisions if they want. That's also, of course, issue. But I have a lot of to speak, for example, about the sexual and reproductive health rights, if you like. Do I continue?
Probably maybe 1 minute if you want to address this,
all
because
right.
we also have another set of questions. Yeah.
Yeah. All right. I could take up perhaps the impact of COVID-19 to the gender perspective. That's something which we have found that even though in Finland we have managed to or succeeded rather well with the COVID-19, mortality is not very high and there's not so much restrictions in some other countries. But however, we have noticed that there are the consequences are different for different population groups. People which have been vulnerable have suffered more, and inequity has increased. And that's something which is really worrying. And that's, as you know, in many other countries, it's usually women, and especially women in vulnerable situations, disabled people, or people which have financial difficulties, or already some substance abuse. So such things which are, in a way, they are weaker position already before the COVID-19. And we have assessed that, and actually just next week will be published a report about the consequences from gender perspective. So there will be, if I remember correctly, on Tuesday it will be published, but already now know that there will be really worrying issues. For example, violence inside families has increased, mental health problems and such kind. I suppose it's the same problem in many other countries, but it's something you should know about the situation before you can do anything. So that's just to start with issues. Yeah, thank you.
Okay, that works. Thank you very much, Ms. Taru, and I'm sure that we'll be able to hear more in the next round of questions. And if you have any links or documents to share in the meantime in the chat box, feel free to do so. So I will now direct my next question to Ms. Deepa. Ms. Deepa works with Sama Resource Group for Women and Health, which is based in Delhi, India. Her work is located at the intersection of public health, SRHR, gender and human rights through research, advocacy, and training. She was a co-convener of the Alliance for Gender Equality and UHC, and has worked with other health movement and feminist initiatives. So Ms. Deepa, Sama has worked intensively on pandemic policy analysis and had an impact on marginalized and vulnerable populations. You have developed a feminist framework based on the lessons learned. So can you please describe the context in India for UHC and also for sexual and reproductive health rights? And like the other panelists, what was the impact of COVID-19? Thank you.
Thank you, Habibu, for the introduction, and thank you to the organizers for this opportunity. It is wonderful for me to be amongst colleagues and to collectively, I think, amplify equitable, resilient, and accountable health systems, which is extremely important at this moment. A lot of what I'm about to say is located in the Indian context, but as I understand, this resonates with experiences in other parts of the world, like colleagues before have spoken. For those who may not already know, the status of the public health system and healthcare in India, even before the pandemic, has been quite abysmal. India, in fact, ranks 145 out of 180 countries on the quality of healthcare and access to it, and equally poorly in prioritizing health budgets. India has also a very highly privatized healthcare system. Almost 60% of expenditure on health in India is usually spent out of pocket by people. Needless to say, this has extremely gender and equity implications in terms of access to healthcare, but also in terms of implications for privatized healthcare, whose burden primarily falls on girls and women. India has over 1 million frontline community healthcare workers who are women, whose rights to remuneration, safe and healthy working conditions, etc., have been ignored for several years. When it comes to sexual and reproductive health and rights, it has also received little priority in our health system. It's been very marginalized. SRH care has been under-resourced. It's also been very discriminatory and with limited access, especially for young people, for persons with disability, for girls and women from marginalized caste, tribes, and religious communities, also for trans persons, sex workers, etc. During the pandemic, things just got worse. SRH care has been really pushed further to the periphery. Maternal health care, contraceptive access, HIV treatment, safe abortion, cancer, tuberculosis, care for survivors of gender-based violence are only some of these areas that have seen a staggering decline. For example, about 1.3 million was a conservative estimate of compromised abortion over 6 months at the start of the pandemic. Even access to maternal health care, which is better recognized within the government's health policies, just fell through the cracks. Even in Delhi, which is the capital and comparatively well-resourced, denial of maternal health care was a serious concern. In fact, Sama initiated a legal action through a public interest litigation in the Delhi High Court to address such denials based on the experience of a young woman who was denied care by 6 hospitals in the capital during the pandemic. COVID vaccination access has also been equitable. It has remained out of reach for a significant number of people, particularly from the most marginalized communities. And Sama has now conducted a study to understand gender gaps in vaccination with the recommendations for policy and preparedness in context of pandemics and similar public health crises. Be happy to share those findings for those who are interested. They can write to us, email us. Okay. Finally, just a couple of more challenges, I think, and concerns which we think are very important. One, despite this immense crisis, the central budgets over the last 2 years actually show a reduction in the overall health and gender budgets, which is really shocking. And with marginal but very inadequate increase for nutrition and totally inadequate provisioning for mental health, although this has emerged as such a huge issue. COVID-related provisions, that is in the context of COVID, there were some provisions made for social security, such as food rations, insurance for frontline workers, etc. But these have all witnessed rollbacks, discontinuation, or limited implementation. This is completely ignoring the need for long-term social security in public healthcare, which is really very frightening and sad, and something that we really need to advocate more strongly for. During the pandemic, the nodal health ministry actually had come up with guidances on reproductive, maternal, newborn, and child health care, recognizing them as essential services, which we thought was very important. But in the absence of dedicated budget or resources and accessibility to them, this has largely remained on paper. So there's really not been any shift in access to care in that sense. I just want to finally conclude this with my last point, and this is something we hear very commonly from communities that we engage with. And it says that Corona may or may not infect us, but hunger, indebtedness, poverty, and loss of livelihoods will kill us. Has been a constant refrain. This has been a very constant refrain, which indicates the imminent long-term impact on the socioeconomic determinants of sexual and reproductive health and access to sexual and reproductive health care of the marginalized. Thank you so much, and I'm happy to come back to respond to more questions.
Okay, thank you very much, Ms. Deepa. And I'm honestly happy that you are mentioning the work of community workers, because last Sunday there was an award that was given to Asia workers. The award was given by Dr. Tedros. So the community workers, it's a really key element in advancing the work in public health. So thank you for sharing this. So my next question is to Mr. Kugon. Mr. Kugon is the Program Director of the Organization for Health and Sustainable Development in Cameroon. He's a medical doctor specializing in sexual and reproductive health and rights, maternal, newborn child, and adolescent health. He's also experienced in advocacy and community development services and providing health services to vulnerable youth. So, Ms. Kugon, you had a youth-led and focused NGO working with adolescents on sexual and reproductive health and rights, gender-based violence, and UHC. So as you know, young people have specific health needs, and they often face challenges in influencing policy decisions. So what gaps have you encountered in terms of gender and youth-responsive health systems, particularly in Cameroon? Thank you.
Thank you for giving me the floor. Well, the first gap encountered in my practice in Cameroon is the experience barrier. And this barrier in my country is often assumed that the more experience you have, the better. And this goes by a local saying, which says experience is acquired with age. And the older you are, the more experienced you are presumed to be. So this practice has been perceived by policymakers and community leaders in our country, and this has been limiting youth participation in policy making, and has impacted, even in my practice as a medical doctor, this practice has, I've witnessed this practice several times, and I remember at times hearing patients talking in the corridor, will this young doctor be able to solve my problem? Is he still on internship, or is he still a student? So in addition to that, certain type of experience, like attending certain schools and working in particular professions, tend to be valued more than others in our country. And those who go to certain schools tend to have more exposure to collaborating with other stakeholders or policymakers or taking part in high-level meetings. These assumptions privilege only a limited number of people and doesn't leave room for diversity in representation. And also, paying too much emphasis on experience by other professionals or experts limit also youth response in meetings. The second gap identified is the limited number of youth voices in meetings. Young people in Cameroon in particular face challenges taking part in high-level meetings, and most of the times they are outnumbered by the number of experienced or experts in the domain, especially in the public health sector. This has led to many young people to be afraid of proposing new ideas or bringing up new strategies to addressing certain health challenges, because they feel intimidated by some of the experts who usually refer to their years of experience before giving any proposition or any suggestions. And as such, these youths are feel unable to counteract these ideas that these professionals have laid on the table. The third gap that we have identified is that the same one and the same youth are always brought to the table to represent youth voices. And most of the time in these high-level meetings is where all the decision-making to cover youth needs are being taken. And most of the times, only one and the same people are being invited to this table. And these youths that are being invited are people who have high-level connection. And most of the times, they are not a perfect representation of the youth voices, because most of the times they are just being given the position due to their connections and their mentors or their godfathers. And with the affiliations that these youths have, they tend to be coerced by some of their mentors or their godfathers to propose youth strategies that are inclined to the activities that their godfather or their mentors want, and not necessarily the youth voice, and not necessarily the needs that the community is facing.
Okay. So I don't know if maybe if you want to conclude maybe in 1 minute before I pass it over to the next panelist. We will come back later so you get the chance to share more on the gaps.
Okay, thank you. So in conclusion, I will just say most youths in Cameroon, they feel unable or unwilling to participate in decision-making process because the policymakers or the experience, those are more experienced in the domain, they tend to lay too much emphasis on their years of experience. Because I remember one time at the regional hospital in Bamenda where I was working, we had a coordination meeting, and one young medical doctor that just finished proposed an idea on taking on chance. Unfortunately, and a more experienced professor told him that with his over 20 years of experience in the field, his idea won't work. And for that, he was the one best placed to offer a solution to the problem experienced by people.
Okay.
So, thank you.
Okay. Thank you very much, Mr. Kogon. And it's really good to hear these perspectives. I think the issues that you just raised can be found in many countries, especially developing countries. So I can definitely relate to that. So thank you very much. So my last panelist is Dr. Veloshni Govinda, who is a health economist with health policy and system experts in the Department of Sexual and Reproductive Health and Research at the WHO. She has extensive experience from both South Africa and India. Her work includes health system strengthening gender and equity issues in the context of sexual and reproductive health and rights, TB and HIV/AIDS. So, Dr. Veloshni, you have a unique global perspective on the panel from your role at the WHO. So from the perspective of gender and gender equality, what have been the overall and global impacts of the pandemic on progress towards UHC? Thank you.
Thank you, Habibu, for that very kind introduction. And also thank you to UHC 2030 and the Alliance for Gender Equality in UHC for the opportunity to contribute to this panel discussion. And I think as we've heard in response to your question, Habibu, as we've heard from Deepa and others, I mean, I think Deepa has spoken very eloquently on the experience of the impact of the pandemic on India in terms of sexual and reproductive health, but in terms of also livelihoods, it's been devastating. And I think that's been really the experience globally. As Dr. Tedros, the Director General of WHO, has called it, he's called it the pandemic of inequality. And we believe, it's not an exaggeration to say that the pandemic has been devastating, especially in terms of gender and progress towards gender equality. If anything, it has taken us back. And it's really impacted, really on all spheres of life. And I think, everybody attending this discussion, panelists and participants, can attest to this, in terms of their own lived realities and experiences. The impact on the home, on the social and the economic environment has been devastating. We've witnessed the impact of lockdowns on women and girls and access to education, economic, food security, how labor is divided within households, violence, and especially in the home has increased. We've heard of that experience even in high-income countries like Finland, caregiving practices, and importantly, even access to social networks, and the list goes on. But when we turn to commitments to universal health coverage, we know that the picture has also been equally grim for gender and gender equality in terms of what's important for how we measure progress towards universal health coverage in terms of financial protection and access to services.
I think also drawing from UHC 2030, the report that was published in 2020 on the state of commitment to UHC, I think there's two important areas that we can see look at the impact of the pandemic. One in terms of employment and livelihoods, and secondly in terms of access to health services. And I wouldn't want to repeat some of the, the very in-depth experiences that Deepa has drawn on for India, but maybe just to highlight one in terms of employment and livelihoods. We know that the pandemic has really impacted in terms of job losses, and this has been particularly devastating for women. And also when we look at access to healthcare, where it's, fees, co-payments are often a barrier to accessing care, where there's not universal health coverage, where access is, there's free healthcare. It means that cost is a barrier to care. And in order to cope, people borrow from families and friends, they draw on their savings, reduce spending on food, and other essential household needs in order to pay for healthcare. And many instances when they're not able to pay for healthcare, they simply forego care. They do not seek care. They miss visits to their healthcare provider. They don't pay for them. They're not able to even pay for vaccines if vaccines were a barrier, or for essential health medicines. And this challenge is also especially important when healthcare is conditional upon private or employment-based health insurance. So stated simply, if you do not have a job, you don't have access to health insurance that's based on employment, then there's no healthcare. And this, we know, has been especially devastating for women. And we've also seen an increase in unpaid caretaking in the home. And this burden has especially fallen on women as caregivers. And this, the cost and the cost on the economic impact, social impact of this, what we know has been huge. We have not been able to kind of really quantify this experience or the implications of it. Mm-hmm. And I think also, as Deepa has spoken of, during the pandemic is a challenge in maintaining essential health services, including for sexual and reproductive health, and at the same time responding to the pandemic, which we've seen also has been a diversion of resources, both in terms of health workers and services towards the pandemic response. And women and girls have been, as well as other vulnerable populations, have been the hardest hit and continue even post-pandemic in terms of the post-pandemic response, continue to struggle to access care. And so we also understand and realize that intersectionality matters, and gender, of course, is non-binary, and gender diverse populations have faced a significant discrimination in accessing care pre-pandemic, and this has really worsened during the pandemic. And when we look at the loss of the health workforce, recognizing that women make up 70% of frontline health workers, including those really at the frontline community health workers. Yeah. Only 25% of them are in positions of leadership, but they've also faced an increased risk of infection. So maybe just in summary, Habiba, just to summarize, is that the processes, UHC processes are still gender blind, and COVID-19, the pandemic, has shown that women and girls are still being left behind. And I'll stop there. But thank you.
Thank you, Dr. Veloshni. Thank you for sharing your insights. It seems that we have a very long way to go to get back on track to achieve UHC, and the pandemic is far from over. So we are now at the next round of our questions. So we took a bit more time than expected. So I will ask some questions, and then the panelists will have 2 minutes to answer the questions. So I will now go back to Mireille to answer my next question. So Mireille, in your role as Permanent Secretary at the Ministry of Gender and Family Promotion in Rwanda, how are you integrating work to empower women and families in Rwanda's goal for UHC? Can you tell us a bit about your recent policy successes or any upcoming opportunities? Thank you.
Thank you, moderator. Yeah, as ministry custodian to gender promotion in Rwanda, we revised policies, including national policy against gender-based violence and the national gender policy to strengthen and enhance gender parity in all sectors and at all levels, and also to specifically engage men and boys in promotion of gender equality and empowerment of women and girls. More specifically, the national gender policy recently approved ensures the gender mainstreaming across sectors and health sector specifically. It also ensures the reinforcing counseling services in safe rooms for girls at primary and secondary schools when it comes to adolescent sexual reproductive health, education, and mobilization for services. We also aim to increase awareness for both women and men, girls and boys, on the benefits of using modern contraceptives methods as far as family planning and reproductive health are concerned, among other policy actions. About one biggest success in the establishment, it was establishment of 44 Isange one-stop center. It's like one at district level. And this Isange literally means feel at home, is they provide free of charge and multidisciplinary services to GBV and child abuse victims 24/7 under one roof. And the services includes medical care, psychosocial support, legal services, and relief and reintegration. We have seen the key role of women structures, the one we call National Women Council that has been established from central level, from national level to the grassroots level to mobilize women and participate in all development programs, including those in health sector. And we have seen their role, key role when it comes to COVID prevention and access to services and other information when we were in this pandemic period. And we are also seeing their role specifically in mobilizing women to attend to the family planning services. I thank you and submit, moderator.
Thank you. Thank you, Mirel. I think we have so much to talk about today, and the session is not, the timing for the session is not enough. So I will probably suggest you, if you have any documents or links, just put it in the chat box. And yeah. So my next question is directed to Taru. So Taru, can you tell us the approaches that Finland is taking to ensure that UHC is gender responsive and can lead to stronger health systems? So what policy measures can you recommend?
I already mentioned this impact assessment, which is a long tradition in Finland already, so that in legislation we take into account that that different population groups and gender is taken into account. That's something I think legislation is the basis for everything. But of course, when we are providing the services, it should be also organized so that these are sensitive to all population groups, and especially while we are thinking about the universal health coverage, the services in Finland, I think it's important that they are near people, so that all these are integrated in an entity where it's easy to get the services, so that they are not separate services you have to seek from some long distance away. And especially we are taking into account the perspective of young people. So it's really important so that schools and universities and all students are provided also services nearby schools. So that's something which is very much used as well. So that these take into account the perspective of young people and gender perspective as well there. So that's something. What else could be said? I think one of the most important things while you organize universal health coverage and services, you need to know where you are, what are the services situation, what are the needs of people. So that applies to everything. You need to know the situation. You can't provide the services which people need if you don't know about the situation. What are the needs and what are the changes, what are the trends there? For example, just now when we are going through this COVID-19 situation, we have tried to follow the situation. As I said, there will be a report next week about the gender impacts of COVID-19, but we have all the time tried to have a situation picture so that, for example, we know that elderly women have been vulnerable. They are caring usually very much about their relatives, as was just said. It's something, a phenomenon which is also very vulnerable situation. And we know that young people have suffered. So that we already have these services available, but we should focus there more the needs of these people. And especially young people have problems with mental health issues, and especially young girls. So that we know that, and now when we are drafting the new way forward for recovery of the COVID-19, we have to take this into account so that we can manage and provide such services which people need, based on separate perspectives, what the situation is and where should be perhaps made better. Or yeah, but you need to know where you are, so you can decide together with the partners or service providers inside there. For example, these family centers are just now in a very key position because families also suffered, especially families in vulnerable situations during the COVID-19. If a family already had some problems, they have more problems now, even though we have tried to support them. And so that's something we have to take into account. This, I don't know if I answered your question. I tried. Yeah, thank you.
No. You did really good. So thank you very much, Taru. And that was an excellent advice. And I really like your point on taking the perspective of young people. And I'm sure Mr. Kungang, who's also on the panel, will have more to say on that when he will address the. He will continue making the statements in this webinar. So let me come back to you, Deepa. Thinking about solutions for gender responsive UHC, can you tell us more about the feminist framework? How do you think it will influence policy and decision making to ensure equitable and resilient health systems? And what else are you seeing that supports progress? Deepa?
Sorry, I was muted.
Okay.
So the intersection feminist framework actually has emerged in the context of the pandemic over the last 2 years. It's a process that was initiated by Sama, and it's based on the pandemic experiences of marginalized communities, learning from frontline health workers and migrant workers, scientists working at the intersections of gender, science, medicine, and public health. So it basically draws on very diverse perspectives, from feminists to queer to young people's, disability rights, health, and other movements. It also offers a feminist analysis that interrogates or analyzes the state's responses or the government's responses to the current pandemic on health crisis. And it also kind of suggests what could be a gender responsive policy and praxis. This is also based on our collective and evolving understanding. It's, I mean, not set in stone, and it's extremely contextual, but this is based on our collective and evolving understanding of this pandemic, but also based on lessons learned from previous pandemics. And we see a lot of commonality and lessons to remember and recall from the past. We also see it as an important resource that can be adapted to inform policy. for public health planning, developing advocacy actions, and also to forge a wider solidarity, which we think is extremely important currently in very, very different locations, not just geographically, but also socially and across movements or networks and alliances. So this is about the framework. And I just wanted to say that apart from this, there have been some very interesting or important spaces for us nationally. For example, in India, the National Human Rights Commission in the early part of the pandemic initiated a committee to really look at the impact on rights of the pandemic. And in fact, my colleague Sarojini was quite involved in it, and we're able to develop collectively or through a consultative process an advisory on the rights of women in the context of COVID-19. And it includes advisories on abortion, addressing GBV, gender-based violence, maternal health, frontline workers' rights, etc. Although this did not really have adequate implementation, it continues to be a very important tool for advocacy and a reference for it. I'll stop here because I know we're really short of time, and I'm happy to respond to any questions. Thanks a lot.
Okay, so thank you very much, Deepa. So we will continue to the next panelist. But before, I would like to thank all of the panelists who started answering the questions in the chat box. So moving on to Mr. Kogong, what policy successes or recommendation can you share with us that support gender responsive UHC and more equitable health systems? Mr. Kogong.
Thank you again for giving me the floor, Habibu. Universal health coverage can contribute to improving adolescent and youth healthcare, provided it is made gender responsive and equitable. The World Health Organization introduced the youth-friendly healthcare services decades ago with the 5 pillars of accessibility, acceptability, equity, and appropriateness and effectiveness. To make universal health coverage more gender responsive, youth-friendly, and equitable, we need to focus on creating adolescent-friendly health services, which could be youth clinics, which will help to act as a safe space for young people to and should be built on the principle of confidentiality and prioritize responding to youth needs. This model is implemented by providing youth-friendly training to a healthcare provider and creating separate rooms or called safe space in health facilities or other organizations where adolescents could meet and have access to health services. In our organization, we adopted this model about a year ago, where we created a sexual and reproductive health and right one-stop shop, where youth could have access to all reproductive health services, such as contraceptive services like family planning, condoms, pills, implants, and others. They could also have access to screening services for STIs and sexual and HIV, including HIV. They could have access to counseling and trauma healing for survivors of GBV and female genital mutilation. And also through this clinic, through this one-stop shop, we also do follow-up of teenage pregnant girls. Through this shop that we started about a year ago, we have reached out to about 100 youths already, most of whom are girls. Although this model worked well, the ever-growing population of adolescents, especially in low and middle-income countries and in sub-Saharan Africa specifically, and the limited number of these shops available, this model has led many youths unattended to, and most of the youths don't know where to find the services that they need. Hence, they need to shift to an adolescent responsive health system approach as instituted by the WHO that integrates service delivery, health workforce, health informatics, medical product, finance, leadership and governance, and community. So due to time, I will stop here. Thank you.
Thank you very much, Mr. Kogong. I will now direct my last question to Dr. Veloshni. So Dr. Veloshni, what policy measures are needed to meet the 2030 target of achieving UHC for developing resilient and equitable health systems that are gender responsive?
Thanks, Habibo. Can you hear me?
Yes, can we hear it very well?
Okay, great. I think that's a big question, but I think a good starting point, I think, for us is just is ensuring that the participation of women and girls in priority setting processes related to universal health coverage. And I think that comes from ensuring that their voices are heard in terms of what services are being provided. Their voices are being heard in terms of how services are going to be financed, where they're going to be delivered, by whom, and also when it comes to how health workers are trained to deliver the services. So I think we really need, increased participation in women and girls, and also other vulnerable groups and marginalized groups in these processes, because for now, as of now, these processes are still very highly technical, and through that, it really discourages the participation of women, girls, and relevant civil society. I think also, what the pandemic has shown us is the impact of affordability. And when employment is really the basis for how people are able to, households, women, and families are able to access healthcare, when healthcare is based on one's ability to pay, is that we need to break the link between entitlement to healthcare and payment contributions. And I think this is, this is really a big push that if we want to make healthcare affordable and accessible, we have to reduce, if not eliminate, the cost barriers, the financial barriers. And thirdly, I think if you want to be able to really understand, one is, again, coming back to the impact of COVID, but also even pre-COVID, the impact of accessing care in terms of costs and out-of-pocket payments. We really need to bring in a stronger gender lens to all aspects of the health system, including starting with the lack of sex disaggregated data. And I think this has been a constant, mantra across so many discussions like this around universal health coverage, around gender and UHC and access, is that we do not have sufficient sex aggregated data. And until we do, we're not going to be able to track out-of-pocket payments through household surveys, and even being able to track unpaid healthcare work, which we know falls on women. And I think we also, so also finally a call out to those of us like you, Habiba, who also work in health economics and financing, is that when we talk about UHC and specifically financial protection, we also need to, acknowledge the gender blindness in health financing and economic research, again, on out-of-pocket expenditure. And there's even less attention that's paid to other forms of inequality and how social identity markers intersect with gender. So I think these are probably the three or four big asks. And I think the last one really speaks to how we address research and research and gender, and how gender is incorporated within that, so that we be better able to track, how gender is tracked within all the work that we do, whether it's policy program and research. Thanks, Habiba, for the opportunity to intervene.
Thank you. Thank you very much, Dr. Veloshni. And thank you also for giving us a global perspective on the progress we still need to make until 2030. We have 7 years left, so there's still more work to do. So thank you very much. So we are now at the end of our interventions from the panelists. And so now we will take the questions of the participants that were put in the chat box. So there are quite some questions that were answered already by the panelists. So I will take the ones that were not answered yet. And then if any of the panelists has any answer, they can open the mic and then provide the insights. So the first one, I'm going to read it. really good to hear discussion on unpaid care and impact on this on women during COVID. I wanted to ask about people's work to promote development of long-term care and support systems as part of full continuum of UHC services, recognizing the key role it can play in promoting gender equity at all ages. So who wants to start? Who wants to answer the question?
I could start if it's all right.
Yeah, go ahead. Thank you.
Yes, as I said, in Finland, the unpaid care, or actually it's paid some, it's not totally unpaid. The relatives, the spouses are taking care of a, usually it's a women who, okay, my video is closed. Sorry, I have noticed. Yes, it's usually all elderly women. I know I have now some problem with video. I don't know. I can't get it.
But we can
on.
hear you, so maybe you can continue.
Yeah, you can hear. All right. I don't know what's the problem. So, but usually they are elderly women, and especially during the COVID situation, there have been difficulty because they have been isolated during the beginning of COVID-19, and because of that they have also the problems concerning mental health and loneliness, even though they are taking care of their spouses. And we have tried to get a picture of that situation, and we have found that there are differences also there between the different municipalities, different regions. So that the compensation which is given to these elderly people always taking care of their spouses is not the similar. And there are differences also. Some municipalities provide so-called holiday days, so that someone else takes care of the relative for a couple of days, so they can be off. And there are some psychosocial support provided for them, but there are some differences, and we are now just trying to get a good picture if there be some legislation concerning these services. So once again, you need the data about the situation, and it's not just money; it's the support they need. They have in Finland been thinking that it's the most important that there is in a municipality someone to be in contact and perhaps have, even though just discussion support, so that share the experiences and share the situation, and on that basis find what services could be there to support their role as a carer, informal care. So different perspectives, not just money, support, yeah, and also different kind of services, which makes them life easier.
Okay. Thank you very much, Taru. Thank you. So we also have another question that was put in the Q&A chat box. So this, so the question, I believe it might be targeted to one specific panelist, but if anyone wants to jump on that, it will be really good. So the question is, what does the national policy against gender-based violence actually do for women and against perpetrators? One person that would like to answer this question?
Hi, Abibu. I could answer it,
Yes.
but
Okay.
I'm not sure if it was directed to someone in particular. Maybe it was to Muriel, because it's talking about a national policy. I think she spoke to that. But I'm happy to respond in general, maybe.
Okay, so maybe you can start maybe providing your insight, maybe for 1 minute, and then if Muriel also wants to contribute, she will come afterwards.
Yeah, so I mean, in terms of, I think it was about addressing gender-based violence. So in India, for example, we don't have a national policy, but we have laws and we have certain protocols, for example, for the health system to address gender-based violence. I mean, I'm not really sure, I'm not able to see the question, Habibu. So was there a particular point on that?
So the
sorry.
question is, what does the national policy against gender-based violence actually do for women and against perpetrators?
Yeah, so in India, the laws and protocols essentially mandate different systems or different institutions, whether it's a healthcare institution or the women's rights, space, to ensure that they provide the necessary care and response for survivors of violence and different forms of gender-based violence, whether it is sexual violence or intimate partner violence, domestic violence, or due to acid attacks or other forms of gender violence, sexual harassment at the workplace. So it essentially mandates what different institutions must do, provides care, both legal, mandates care, also provides support through health systems, or at least this is what is there in the law and in these protocols. Of course, it's a huge challenge to actually implement them as they should be, and that's been a big struggle for a lot of organizations, activists, and people who are working on the ground. Also, I think someone else mentioned it earlier in terms of patriarchy and in terms of caste and other axes of marginalization. There's a lot of stigma, a lot of blaming of women and other marginalized in terms of gender-based violence. So it's typically seen as a private issue and not to be brought out into the open and addressed. So yeah, I don't know if that really answers it, but.
Okay, thank you. Thank you very much, Deepa. I think it's really good that you are bringing in your perspective on this. So we will now wrap up.
1 minute.
Thank you again. Yes.
Sorry, Abibu, you asked me to add maybe something.
Yes, go ahead. Please go ahead.
For the GBV policy and its law, because we are having both the law against gender-based violence and also the policy. There are some actions specifically on the prevention side, but also on the response part, as Deepa said. We do have the Isange one-stop center. As I mentioned, the Isange that provides multidisciplinary services, including the counseling, the legal support, and the reintegration part also. And also linking to the policy, we have what we call linking to the legal service. Also, we have what we call sex offender registry that was launched in 2020 that have all the names and age for the perpetrators, because we want this shaming and making accountable people to know those perpetrators and to know how they not in line to discriminate them or to exclude them, but also to make the community aware who are their neighbors, who are there. Because sometimes you see those perpetrators having exhausted their fines, so they go back to the community. They are teachers, they are like welcomed to other communities. So we want to know these people, and we think it will maybe prevent others to do so, to avoid being on that list. Thank you.
Okay, so thank you very much for this. I think we will start wrapping up. It's already 15, and I would probably give the floor now to Ms. Gabriela Cuevas-Baron, who is the co-chair of UHC 2030 for closing remarks. So Gabriela has been a member of the political advisory panel of UHC 2030 since 2020, and she has had an active political career in her home country of Mexico. She has been a federal member of parliament 3 times, a local member of parliament, and a constituent member of parliament in the Constituent Assembly of Mexico City. Additionally, she was the first woman to be elected mayor of the Miguel Hidalgo delegation. That's quite impressive. So thank you, Ms. Gabriela. The floor is yours for the closing remarks.
Thank you. Thank you so much, moderator, and thank you all panelists, the speakers, and participants for your wonderful contributions. I was particularly interested by the policy suggestions and all the different needs that were addressed during the different participations. I believe that the first participation was very important in terms of addressing the need, the importance of redesigning our social contract, of course, with women and girls' lens. I have been a politician all my life, so I believe that we really need to rebuild public trust, and that means a new social contract, understanding that women and girls are fundamental in our society and in every development. It's not only about a narrative, it's a fact. We also heard a lot of different participations on the importance of legislation. We heard the example of Rwanda or how Finland has
Sorry, Ms. Gabriela.
Yes.
Sorry to interrupt you. There's some noise behind, so I'll probably ask the person who has the mic open to probably close so that Ms. Gabriela can continue her closing remarks. So can you all please close your mics? Thank you very much. Okay, you can go ahead, Ms. Gabriela.
Thank you very much. So I was mentioning about the importance of legislation and how Rwanda and Finland were very good examples during these conversations. Nowadays, still 21st century, 2.5 billion women and girls are still being discriminated by their national laws. So legal frameworks that guarantee equal rights and right-based approach are needed. We cannot take for granted what we have gained. There are a lot of things that we still need to do. And that goes, of course, to the issues related to health. Leadership. Leadership is truly important, and it goes from the community level to decision-making seats. We need the mechanism and priority setting to be sure that women are going to be included in all decisions. Yes, women have been at the forefront of the pandemic and services and saving families every day, but we are not part of the important decisions that are taking place. So we need to be equally represented. Then community focus to better understand and respond to needs, give voice and participation in policy making. We heard about maternal and childhood clinics in Finland. This is a very good example on how we need to design UHC that is fully inclusive and that also consider the specific needs of women and girls, from specific diseases to specific medical equipment, as women in global health is proposing. We also need to understand how primary healthcare and primary social services are linked to build infrastructure and the network that women and girls need. Social services are also essential as poverty is not gender blind. There are still deep inequalities that the pandemic exacerbated. Health is a human right, it's not a privilege. It was mentioned here how some health systems are almost privatized. The first step to fight poverty is implementing UHC, as people won't be in poverty because of sickness. We also, and it was, I think, something very important that was mentioned here, we need to have better consideration of unpaid care provided by women. We can't forget about people in vulnerable conditions. We have to be sure that everyone is included, especially people in the most vulnerable conditions, people who are constantly excluded. Sometimes those vulnerabilities are overlapped, and it includes women and girls. We heard amazing policy suggestions and tools, such as publicly financed PHC, gender impact assessments, gender budgeting, sex disaggregated data, gender-based violence policy, intersectional feminist frameworks, and one-stop shop for all youth health and social services. One important lesson that we learned from the COVID-19 pandemic is that to achieve both UHC and health security, countries must invest in resilient and equitable health systems based on primary healthcare. But we also know from our discussions and experience that for health systems to leave no one behind, we must prioritize gender equality across the dimensions of governance, health financing, and service delivery, and ensure women have an equal voice in decision-making. The sad truth is that governments are not adequately addressing gender equality in their UHC commitments, especially women's representation in health and political leadership. In addition to the excellent resources and messages shared today, UHC 2030's paper called Action on Health Systems for Universal Health Coverage and Health Security is another great tool to help us achieve our goal to build resilient and equitable health systems that respond to the needs and priorities of people of all genders. A strategic narrative to guide national, regional, and global advocacy and action. It brings together recommendations from recent high-profile initiatives and reports, focusing on priority actions and the roles of different partners and constituencies. This shared script provides a basis for UHC 2030's diverse membership to, first, promote political leadership for stronger health systems. Second, to mobilize better aligned resources for health systems, for UHC, and for health security. And third, to demand an act for solidarity and equity in health systems. With the recommendations and lessons learned we have shared today, I believe we have everything we need to accelerate action toward gender-responsive UHC and to mobilize support for relevant policy actions. Now, we just need to continue dialogue and transform words to action, which could take the form of a tool to guide policymakers in making health systems fully gender-responsive. To drive change, we need stronger accountability. Such a tool could provide a powerful resource for all of us to ask governments to take the right action and hold them accountable to make reforms in the right direction. Let's go to work. I look forward to collaborating with you. I'm sure that we can rebuild this social contract and, of course, to have women and girls present in every decision, in every latitude of the planet. Thank you very much.
Thank you very much, Ms. Gabriela. I think this was really good in terms of concluding remarks. And thank you also to our eminent speakers today. I think we definitely need another session to cover all of the topics. This has been an inspiring discussion, and it has reminded us that for UHC to be universal and leave no one behind, it must reach all women and girls, and it must also be gender responsive. So stay with us on the journey to the UN high-level meeting on UHC in September 23. And thank you again for being with us today. I will now close this meeting and wish you a nice day or evening, depending on where you are in the world. So thank you very much. Thank you to the interpreters. Thank you to the panelists. Thank you to the people also that were behind organizing this event. So thank you all and have a nice day.